we would like to open podium for discussion and answer your questions. I want to invite all panelists, our distinguished colleagues, Dr. Seza Gulec, Dr. Sarah Mayson, and Dr. Marina Nikiforova to join me. And we have also some cases to discuss, but I thought that we would like to start with your questions before we move to cases. Let's see. Okay, so I see here just one question. What is thyroid differentiation score, TDS, and how do you calculate it? It's a very good question. I probably will take it, this question. So thyroid differentiation score has been introduced by the TCGA study that I discussed in the first part of my talk. And also, I think that Dr. Nikiforova mentioned it in her talks, which evaluates the expression of thyroid differentiation genes. What are those genes? We all know them. It's a thyroglobulin, TSHR, NES, dioxidases, and so on and so forth. Okay, and the expression of these genes is believed correlate with the differentiation status of cells, and clinically more important with probably iodine avidity. Although I want to stress that this is still a moving target, this is work in progress, and it have no, to my knowledge, has not been direct link between the thyroid differentiation score and avidity to iodine. So I invite my colleagues to pitch in. If you, Dr. Gulec, I know that this is areas of your very big interest. If you would like to give thoughts on this.
Well, as you said, this was first mentioned systematically in that 2014 paper, the Integrated Genomic Analysis of Papillary Thyroid Cancer paper. And the genes mentioned in that paper were the 16 genes involved in iodine handling, as well as iodine handling in the peripheric tissues. These were the transport proteins, NIS, pendrin, and TPO, DUOX2, DUOX1, DIOX1 and 2. These were, and besides this TSHR and the thyroid specific transcription factors, 4 of them, altogether 16 genes were listed under this. Then another paper in 2019 from Memorial Sloan Kettering Group identified 50, I believe 54 or 53 genes. Some of them are positively associated with thyroid differentiation, and some of them are negatively associated with thyroid differentiation. When in these two studies, the listed genes are listed because they are associated with thyroid differentiation, not necessarily directly relating to iodine handling. Our group, we started looking at this, and actually we decreased the number of molecules or genes directly involved with iodine handling. So as you said, this is still work in progress, but available data indicates that thyroid differentiation score correlates with a number of things. It correlates, inversely correlates with ERK MAP kinase output, directly correlates with clinical outcomes, BRAF, RAS score, and risk stratification categories, high risk, intermediate risk, and low risk. All these parameters, and also histology, and also follicular component of the histology. These are all correlated with TDS. We have only anecdotal data, anecdotal information that TDS may, and in theory should, correlate with radioactive iodine uptake, because the cumulated activity as defined in the time activity curve involves all these listed genes. I gave a long answer to your short question,
Right.
but TDS is going to prove to be, in my opinion, is going to prove to be an important factor in decision-making, clinical decision-making in terms of surgery and radioactive iodine treatment.
Right. Probably it will, although likely it will be, I would call it modified TDS, correct, because I think that not all genes on the panel, correct, they really have direct correlation with really sort of the avidity to iodine and so on and so forth. And how do you calculate it? I want to refer you to that paper in Cell in 2014. There is an algorithm, computer algorithm described how you calculate it, but you need to have a whole transcriptome analysis, expression of all genes, in order to calculate the TDS, thyroid differentiation score. Any other comments from the panelists? Then I go to the second question. Did you do a retrospective review of Thyroseq for MAC1, similar to the look back you did for GLIS 1-3 and DICER 1? Yes, we did. In fact, that we look at a very large series of tumors. We look at about 700 papillary thyroid carcinomas, and we look extensively. We are very interested also in Hürtel cell tumors and follicular carcinomas, because also a small proportion of them lacking other alterations. And we did not find MAC1 mutations in any of those tumors. It was really specific for papillary carcinoma. And speaking about the score, I mean, as Dr. Nikiforov showed, all of those tumors had high TDS score and were RAS-like follicular variants of papillary carcinoma. Let's see if there are any other questions at this time. I don't see it. I mean, we give you a little bit of time sort of to come with questions. We'll start discussing cases, but please just feel free to ask any of the speakers about any of the points that we discussed or we did not discuss during the today course. Meantime, we start with the case presentation. So first case is a 59-year-old woman with 28 by 17 by 19 millimeter left asymptomatic lobe nodule. Unfortunately, I have only one ultrasound image that was landed by my clinical colleagues. I don't know, Dr. Mayson, if you would just give us if you can give us any kind of, interpretation of what you see on this image.
Sure. So overall, I would describe the echogenicity of this nodule as heterogeneous, although it's mostly hypoechoic. There do appear to be some cystic areas within the lesion, but it's predominantly solid. It's a little hard to see the borders of the nodule in this image, but I would say that this is at least consistent with like ATA intermediate suspicion pattern, which would be TIRADS, probably TIRADS 4, although I'd have to add up all the points.
Great, thank you. So a fine needle aspiration was performed, which was positive for FL-US. I mean, possessed the 3 follicular lesion of undetermined significance, predominance of microfollicles, colloid is present. That was a description. This molecular testing was ordered. It was a Thyroseq was ordered, which revealed DICER 1 mutation. Just what we discussed just before. Common mutation at 11% allele frequency. There was no other DICER mutations. There was no copy number alterations. There was no gene expression alterations. The case was reported as test was reported as currently negative with low probability of cancer, and active surveillance was suggested. Okay, so patient follow-up was stable. a patient didn't undergo surgery for 2 years. And then her doctor got nervous. She found a different physician, and physician didn't feel comfortable, repeated FNA. FNA was FL US again 2 years later. And Thyroid again had a DICER1 mutation and pretty much remained unchanged. So before I continue, I want to ask Dr. Mayson and Dr. Gulec, what would be your feeling based on the provided information? What would be your level of comfort to suggest to this patient?
So, based on what we've learned so far, I would be comfortable continuing active surveillance for this person. I would take a clinical history to ensure there's no remote history of childhood cancers that would make me concerned that they had Dicer syndrome. I would evaluate the lateral lymph nodes to make sure there was nothing concerning there, because that's an important component. But based on what we know so far, I would be comfortable monitoring this person.
Very good. Dr. Gulec, what would you do something differently?
Well, I've been doing this for 30 years. I never missed a cancer. I won't let anyone ruin my reputation. I'll do a lobectomy.
Very good. So may I ask you, based on what, and based on the size, based on the still presence of a clonal mutation, based on other parameters, assuming that what Dr. Mayson was saying, there is no lymph node, there is nothing else that is of significant clinical concern?
Well, ultrasound look is concerning. It's a solitary lesion, and malignancy risk is not non-existent. It probably is an indolent or slow-growing lesion, but apparently it concerns the patient. It concerns the attending physician. If they're concerned, I'm concerned. So it's not purely a genomic-based decision. It is a medico-social and all things considered kind of decision.
Okay, let me rephrase the question. If the patient trying strongly to avoid surgery, would the index of suspicion was extremely high to force surgery in this case?
Then I'm okay to follow this. I have patients with this size. I have 2 patients with this size, proven papillary carcinomas that refuse to have surgery. We're following.
Very good. So in this situation, patient, like exactly you said, decided to go for lobectomy. On lobectomy, there was a benign node. Okay, I think that this case just illustrates that I think that there is a reasonable additive value of molecular testing to the all other clinical parameters. I first to stress that under no circumstances molecular genetic results should be taken in isolation or as the only way to manage nodules. It has to be a decision based on obviously ultrasound, family history, patient preference, so on and so forth. But that's something that probably will add to the repertoire of other tools that we have to evaluate patients with such conditions.
Yuri, I just want to add for this case that what is also important to understand that DICER1 was a single molecular alteration in this patient and was not present in combination with other molecular alterations. Sometimes DICER1 present with copy number changes in younger patient, and its profile of these nodules much more aggressive profile. It will be more worrisome for the patient. Or if it's found with another more aggressive type of mutations, that will be also more concerning.
That's very true. DICER1 mutation we recently described as a most common alteration is in early sort of in younger patient poorly differentiated thyroid carcinomas, pediatric and young adults. This is true. So there is one question that is asked: why there is no microRNA expression analysis in Thyroid? I think it's a good question. I can take this question. I can tell you that when microRNA became sort of known as something that really sort of present and altered in thyroid cancer, it was around 2007, 2008. We were actually very excited. As people who studied thyroid cancer biology, we were very excited. And we immediately rushed to study. And if you look at our CVs, and Nikiforov and myself, we published 6 or 7 papers every year. We published, and we were very excited. We really hope that this will be something that we will add to the mutation gene expression panel for molecular testing. Unfortunately, when after 4 years studying it, we realized that there is no additive value of microRNA in our hands. We could not see it. We could detect alterations that could detect cancers that have obvious mutations like a BRAF cancers or gene expression driven, and all borderline or more difficult tumors we could not detect using microRNA expression analysis. That was the reason we pretty much sort of, rolled back our research program, and we didn't proceed with including this type of analysis in ThyroSeq test.
In addition to this, it was microRNA show extremely poor performance in Hürtel cell nodules. Basically, all Hürtel cell nodules in our studies were missed, so it was no any additional information gained with microRNAs.
Okay, very good, thank you. While we are waiting for next question, we will go for the second case. So case 2. Case 2 is a 34-year-old female with a multinodular goiter, initially identified by her during pregnancy. No previous history of thyroid disease, never taken thyroid medication, no symptoms of hyper or hypothyroidism, no voice change, no history of radiation exposure, no family history of thyroid cancer. Currently comes to see her endocrinologist, and she is breastfeeding 8-month-old infant. Labs, you see TSH and calcium level. Dr. Mayson, maybe just a quick sort of, your first reflection, and I want to tell to the audience that our panelists don't know, have not previewed these cases, and I put them on the spot, for which I apologize, but I hope you just give us a very general comments on, at this time, how you feel about this patient.
Well, we know that in pregnant and postpartum women, there is a slightly increased prevalence of thyroid nodules, and that pregnancy itself may cause some growth in thyroid nodules related to the hormonal changes. So right now, hearing about this case, so far I don't have any out of the ordinary concerns. It just seems to be a recently postpartum woman with a palpable nodule. And I anxiously anticipate the rest of the case.
Very good, thank you. Okay, so this patient, this is patient ultrasound, which was focused on 3 nodules that she had. She had a left upper lobe nodule. You see the dimensions, 2.6 by 1.6 by 2.2 millimeter solid, homogeneous, isoechoic, well circumscribed. Perhaps, Dr. Mayson, maybe you can in real time just give us a little bit of your sort of, first impression of each of these 3 nodules, that 2 of them were in the left lobe and 1 in the right lobe.
Sure. When I looked at the image on the far left, to me, it looks more isoechoic on that image. It has nice, well-circumscribed borders, completely solid. Generally, this would be considered ATA low suspicion pattern, which I would have said TIRADS 3 for that one. And because to me, it doesn't look hypoechoic. But the one thing I would mention is that it does have a bit of a thickened and irregular capsule, which is not part of those classification systems, but may be more associated with potentially as a marker for malignancy. The one in the middle panel is mostly cystic hypoechoic, has mostly solid hypoechoic, one small cystic area in the middle, a couple of indeterminate echogenic foci, potentially microcalcifications, though not clearly. And this one on my computer, I'm also having a little trouble with the margins, but they look pretty smooth and thin. And then the last nodule on the right is on my view, slightly hypoechoic. It again has a thickened and irregular border.
Very good, thank you. Overall, like you said, none of them are highly suspicious, but somewhere in a kind of a low to intermediate suspicion ultrasound. Would it be fair to say about those three nodules?
Yeah, I agree completely.
Very good. So these three nodules were FNA. All three come back as Bethesda 3 cytology. Nodule 2.6, 2.4, and 1.4 cm nodules in the left and right lobes. Molecular testing was performed on all of these three nodules with the following results. In fact, actually, this nodule, the upper left lobe nodule, was negative for alterations, but had low proportion of thyroid cells. Sometimes it's a stromal hyalinization, sometimes it's lymphocytes, but it was negative, but we said that we cannot really provide a very accurate cancer prediction in this nodule. So negative, but low thyroid cell proportion. The nodule in the center, which was a lower left lobe nodule, was positive for HRAS mutation and for gene expression alteration, with the predicted probability of cancer on NIFT-P at 70%. Another point I want to stress that, as remember, we discussed that if it's an isolated RAS mutations, typically it's a if it's a cancer, it's obviously RAS-like, more low-risk cancer. And the smallest nodule in the right lobe revealed actually NRAS and TERT mutations and copy number alterations. So this nodule was positive for NRAS, TERT, and CNA. Couple points here. One, you see that HRAS and NRAS, so this is definitely, there is no clonal relationships that are totally separate nodules, which I can tell you is not entirely uncommon in the thyroid. We have published many years ago that we look at 2-3 nodules and they frequently have very different molecular profiles. But this nodule has NRAS, has TERT, and has copy number alterations. So at this point in time, Dr. Mayson, Dr. Gulec, Dr. Nikiforova, your sort of, your impression.
Goes first. I'll take it. On the 2.6 centimeter, this is the equivalent of non-diagnostic, my interpretation of thyroid-seq. The second nodule is HRAS positive. This is a neoplasia, period. There's 50% chance that this is a follicular adenoma or NIFT-P, 50% chance that this is follicular cancer or follicular variant of papillary cancer. The one on the right side is very likely to be malignant. You have, in addition to the RAS, you have TERT mutation and CNA. This is a total thyroidectomy.
Dr. Mayson, any comments, additional comments?
Yeah, I agree with the management recommendation. The right-sided nodule has a high likelihood of being a high-risk malignancy. This is a very young patient. The other two nodules on the left are both quite large as well. One of them also has a moderate risk for malignancy. So in this situation, I would recommend also a total thyroidectomy, both assuming that the right-sided lesion is going to be high risk and the patient may need other therapy depending on their pathology results, and also knowing that this patient has quite large nodules on the left side that don't have no risk for malignancy either. And I think it would make the most sense in this particular patient's case to do a thyroidectomy.
Dr. Mayson, if these nodules were not this big, say 1.5 centimeter all, would you have done anything different?
You know, given the molecular profile for the right nodule, I'd be worried that this is a higher risk cancer. So I would still probably recommend the total thyroidectomy in her case, unless the patient was really opposed. Another option is to also, you know, rely a little bit on the intraoperative impression of the surgeon, you know, to help make that decision. But just given the combination of NRAS TERT and the copy number alterations, I'd be more worried about this patient and wouldn't want to have to go back and do a second operation.
So now, Dr. Nikiforova, you want to say something? No?
The only thing I can add to this, because I'm looking from molecular perspective, not from clinical management perspective, I honestly don't like the type of TERT mutation that was found here, because majority of TERT mutation, it's different codons, minus 228 codon, and this is 250. And this is kind of more rare type of TERT mutation, but anecdotically, it's found kind of in more aggressive tumor types.
That's actually a good point. I also want to say that allelic frequency of these mutations is very high. That's another something that we really we don't have a very, very solid sort of cutoff, clear kind of, but when we see it's high, it's highly clonal tumor. Now, before I show you the surgical outcome, I want to ask you this, all of you these questions. So let's say that the center nodule in the center, sagittal left, left lower lobe nodule, positive for HRAS mutation, with no any other alterations. In a gland, in one lobe, this second lobe has nothing, there is no nodularity, patient is not hypothyroid. What would be your recommendation for surgery, if surgery performed for such patient?
So if that middle panel is the only nodule the patient has with the HRAS mutation, then I would recommend a lobectomy for this person, help them to preserve their other lobe, hopefully not need thyroid hormone, although some people do after a lobectomy.
Dr. Gulec.
Totally agree. I concur.
Very good. Now, a little bit more difficult question. If this patient has only right lobe 1.4 cm nodule, and there is no other nodules, this is a single nodule in the patient. A little bit touched on this, Dr. Gulec question, but there was a question, there were two other nodules, but small size. If this is a solitary nodule with positive for RAS, TERT, and copy number alterations, what would be your recommendation for this patient?
Who goes first?
Let's start with the endocrinologist and then we turn to the
right.
Yeah, I think this is harder. Again, this has a risk for being a more aggressive malignancy in this young person. I think I would, counsel the patient about that risk. It's possible that there would be no vascular invasion or anything like that with this nodule, but I don't know. I think there would actually be a moderate risk there is, and then we'd be stuck going back. But I would kind of counsel the patient on both possibilities. And if it was my neck with that mutation, I would probably have a total thyroidectomy.
Dr. Mayson, what if I tell you that, and we are going to discuss about this tomorrow at the main symposium, that there are pretty solid data in our hands that we just published, that this molecular profile is associated with 30 to 40% probability of distant metastasis in 5 years.
Yeah,
right.
That's impressive, and that's why I would favor that full thyroidectomy. I almost wouldn't believe the pathology if it didn't show that this was an aggressive malignancy. And I know there's a series out of somewhere in Scandinavia, I think Heisek, was the author, where they showed even in the follicular tumors of undetermined potential that they later had recurrences and distant metastases. It was a very small series. So I do think in the setting of TERT, those were isolated TERT mutations. So again, I would recommend a total thyroidectomy, but I would counsel the patient about both options.
Dr. Gulec.
This is a tumor that I would definitely do a total thyroidectomy because of the NRAS mutation. This is malignancy. This is cancer. NRAS she's going to have a high TDS and very high chance of remote distant metastases that can be taken care of with radioactive iodine. If this was not an NRAS TERT mutation, but BRAF TERT, I would have, this size tumor, I would have done a lobectomy and look at the postoperative surgical pathology features. And again, if possible, look at other ways of assessing radioactive iodine responsiveness of this tumor. Total thyroidectomy, and I'm going to discuss this tomorrow, is totally linked to radioactive iodine need. Otherwise, a unilateral lesion confined to the thyroid, this purely surgically speaking, none of these lesions require total thyroidectomy. The only reason we do in these lesions, intrathyroidal lesions, do a total thyroidectomy is the anticipation of radioactive iodine treatment.
So, very good. I wholeheartedly agree with a small caveat, and I don't even know if this is a more theoretical or practical. We know that BRAF-like tumors, they have a higher rate of lymphatic invasion and intraglandular spread and lymph node spread. So let's for a second put aside the lymph nodes because we will discuss it next. But let's even assume, I really don't know, for example, nodules that is located close to isthmus, is there any chance that there would be dissemination to the opposite lobe? At least in the old literature, I remember, I don't know if any data exists, but perhaps something to ask you about.
I'm not aware of any data of this kind of dissemination. There is a possibility of bilaterality. That's about 10–11%, but that's an independent issue. It's a multifocality issue, not intraglandular spread issue.
Right. So perhaps I have a different look because I'm a pathologist, and I look at the tissue, and I can tell you in many patients with BRAF-like tumors, when you look few millimeters from the tumor, you see seeded cells in thyroid parenchyma. We rarely report it because it's sort of kind of, we believe it's irrelevant, but I do see it. Again, this is just my experience. I'm not trying to kind of say that this is something that absolutely have to dictate the clinical decision. Now, my question, another question for you is, in this patient, how hard you would do imaging for lymph nodes, looking for lymph node spread of the tumor before surgery?
It's a critical question. We look very hard. Anybody with, are we talking about BRAS or NRAS?
No, we are talking about this patient with NRAS.
Well, I wouldn't be, she would need definitely a thorough neck ultrasound, but that's where I would stop. If this is a BRAF tumor, I would then definitely do a cross-sectional imaging.
Can you perhaps for the audience one more time just explain the logic behind this?
The logic behind is BRAF tumors tend to stay in the neck and they present as nodal metastases. We actually, if there is a more than one mutation, really high risk tumors, we do cross-sectional imaging of the neck and the chest, not to miss level 7, because level 7 is very difficult to see on ultrasound, and very commonplace for recurrence if not properly investigated.
And RAS-like tumors?
RAS-like tumors, for neck, a good thorough neck ultrasound will suffice.
Dr. Mayson, any additional comments before I move to the clinic, to the surgical pathology in this case?
No, I don't think so.
Dr. Nikiforova, any additional comments?
No comments from me too.
Okay, so patient underwent total thyroidectomy, and the nodule in the left upper lobe showed 2.2 cm encapsulated follicular variant of papillary carcinoma with minimal capsular invasion. Nodule in the lower left lobe, RAS positive, showed 1.5 cm, slightly discrepant inside, but it does happen from time to time. Follicular adenoma with cystic change in left mid to lower pole, and nodule in the right lobe revealed angioinvasive follicular variant of papillary carcinoma with minimal capsule invasion, but more than four foci of angioinvasion. Your final comment for this case?
So we did the right operation. She would definitely need radioactive iodine treatment. And this puts us discussing what the intent of a radioactive iodine treatment would be. It's what we call adjuvant intent. Different dosage recommendations have been made for these patients. If there is no clinical evidence of metastatic disease at this time, my personal choice is giving 100 millicuries. But people, based on this aggressive expectant behavior, could choose higher dosage, which I wouldn't disagree.
Dr. Mayson.
Yeah, I agree we did the right surgery. I think, you know, one of the things we saw here is that these nodules had the thick and irregular halo. So just to point out, the two that were malignant did have that halo. And I think that in the future ATA guidelines, thyroid nodule guidelines, it's something we're going to consider trying to include as well. We've been discussing that. And then the other comment is just that this person is still lactating. And so when we're thinking about radioiodine, she would need to have cessation of lactation for a period of time, at least a couple of months before receiving radioiodine treatment. So those are the only two things I had to add.
Well, that's an excellent point. I totally forgot that part of the history. Lactating breasts express sodium iodide importer, and they are strongly avid pickers-uppers of radioactive iodine. That would be extremely important to stop lactation at least 4 to 6 weeks.
Very good. Now, I came back to, I brought back the ultrasound description because of the questions, two questions that we received from the audience. Question from Dr. Carolina Ferraz. Would you also suggest central neck dissection for NRAS TERT positive tumors? Before I let Dr. Seza, Dr. Gulec to answer it, I just want to show that, at least per description of ultrasound, it's a central compartment, no abnormal lymph nodes, lateral, no abnormal lymph nodes. Dr. Gulec.
When you have a negative ultrasound, well done negative ultrasound, I personally don't do diagnostic central compartment dissection. Up until 10 years ago, we routinely did central compartment, not only for diagnostic purposes, but also expecting a positive outcome. That was a preemptive dissection to prevent nodal metastases, but it hasn't shown to affect the overall outcome. Since then, we stopped doing it. I don't do them. If the patient later on in the next 2 years presents with nodal metastases, nothing is missed, can have her surgery then.
So, and again, in light of the fact that this is a RAS TERT positive tumors.
It's not going to be the neck.
Right. Okay, very good. Dr. Mayson, anything to add? Very good. The next question is, any nodes obtained in this case? So I was just going through the past report on this case. I think that there was like 2 lymph nodes, probably incidentally taken next to thyroid, and they both were negative. But I don't believe, based on the report, that there was an active lymph node dissection performed in this case. Okay, very good. It's 4:43. I think that we have time. We don't have. Oh, let's see. There is another question. Okay.
Yuri, I also want to add some comment about the case. I want to, basically, from my personal opinion, I'm very happy that all 3 nodules were FNA'd and sent for molecular analysis, because as we can see, each nodule showed different molecular profile, and that basically underlines importance of testing different nodules. We cannot assume that one nodule will have, if it will be more benign looking nodule, second will be the same looking the same. So in this case, it was smart decision to do all 3 nodules.
It's a very good point, and in fact, somewhat ironically, the smallest nodule out of 3 shows the worst molecular profile and the most aggressive histology, and probably would eventually determine the risk of this patient to develop recurrence. Yeah, that's a very good point. Looking back, Dr. Mayson, is there anything in this 1.4 cm nodules that now, knowing everything, knowing molecular and pathology, is there anything specific that would be, that you would be able to see ultrasonographically ahead of time to say that no, even the nodule, that this nodule absolutely needs to be FNA?
Yeah, the only thing worrisome about this nodule is the halo. I think they read it as isoechoic on my computer. It looks slightly hypoechoic, but the only thing that concerned me was the halo being irregularly thickened. So I would have also chosen to FNA this nodule. On the other hand, the one that's on the far left panel really doesn't look as concerning, has a slightly thickened halo, but overall looks, I think, the most reassuring. And I think it was a relatively non-invasive malignancy.
Very good. 2 more questions. One, would you do a TG prior to ablation, and how will you use it?
Was that for?
Would you do a TG? I guess serum TG to see a level prior to ablation, and how will you use it?
I can answer that. So at the University of Colorado, we typically actually measure preoperative thyroglobulins, and we do so for a couple of reasons. I know it's not recommended in the guidelines, but Dr. Haugen, who's the head of the division here, he started this practice, and I love his rationale for it, which is, number one, it gives you an in vivo, essentially, marker of how well the tumor itself makes thyroglobulin. So is it as elevated as you would expect? It to be that in itself, it doesn't, the thyroglobulin degree of elevation wouldn't predict if it's a benign or a malignant nodule, but it would give you a marker of how good that nodule is at making thyroglobulin if it does prove to be a cancer. And we like to see the difference between the preoperative and the postoperative level. Does it fall to an appropriate level after it was elevated preoperatively? In addition, if the patient had thyroglobulin antibodies present, then you can see if those thyroglobulin antibodies are interfering with your ability to measure the thyroglobulin, because in some cases, most cases they do, but in some they don't. And in those cases, your immunoassay thyroglobulin would still be a reliable marker if there wasn't negative interference. And then postoperatively, I would measure the thyroglobulin as well and compare it. Postoperatively, typically the thyroglobulin level should be less than 2. Here we're typically used to seeing less than 1 if there's been a complete resection. So I do find it informative. I think in this particular patient's case, I would still recommend radioactive iodine therapy with her pathology and all those foci of vascular invasion as adjuvant therapy, as Dr. Gulec described.
Very good. Thank you. Another question, very good question from
Can I ask a question?
Please. Please.
I'm not certain how a preoperative thyroglobulin is helping. Thyroglobulin is a product of functioning thyroid tissue. Good part of it preoperatively comes from normal thyroid.
Yeah, I agree.
So we don't know the contribution of, percent contribution of the malignant piece, particularly if it's a small tumor. How could you estimate the contribution from the malignancy?
You can't, but let's say that you measured the preoperative thyroglobulin with, with a nodule that turns out to be a thyroid cancer, and the preoperative thyroglobulin is say 10, which is much lower than you would necessarily potentially expect it to be, or some lower value, then post-operatively, I may not put as much stock in that as my tumor marker, as if it was a more appropriately elevated value based on the size of the gland and the size of the nodule. And I also love using it again as that in vivo assay for interference with thyroglobulin antibodies present, which we see in what 10 to 20% of people with thyroid cancer.
I'm still not clear.
So we'll discuss it over a glass of wine next time we meet.
Okay.
So next question from the audience. Are you surprised that none of the tumors were RAF, meaning BRAF positive? I assume probably based on the ultrasonographic presentation. Dr. Mayson.
No, not necessarily. I think that, you know, none of these have the appearance of a classic PTC, which would be a more hypoechoic lesion that's solid with, you know, microcalcs or regular margins and so forth. So none of these nodules that are shown here have that classic PTC appearance, which we associate with BRAF V600E mutations. So no, I'm not surprised that these are not BRAF V600E mutated nodules.
In fact, with these nodules that are very homogeneous, no microcalcification, smooth borders in most of them, would you even more expect, I mean, if there is a mutation, it would be RAS-like mutation in such nodules?
That's correct, yes.
Cool.
Also, cytology report doesn't suggest any BRAF mutations frequently are reported as suspicious for malignancy based of nuclear features of PTC, which is easier detected than RAS positive nodules.
That's a good point. So we have about 10 minutes. Are you still fresh enough for one more case? Okay, let's do it. This will be the last case that we are going to discuss today. So this is a 44-year-old. This is actually a case that we discussed at the multidisciplinary tumor boards a couple months ago, but I thought that this is an interesting case. 44-year-old female, history of hyperthyroidism, resolved on its own. Thyroid ultrasound revealed a 2.1, but 1.6, but 1.7 cm, well circumscribed, slightly irregular nodule. Physical exam, nodule measure about 2 cm. Subclinical hypothyroidism, I just sort of going through the main. Patient was advised to have a FNA of 2 cm nodule. Okay. So this is an ultrasound. I don't know how good is the image, Dr. Mayson. I don't know if you want just very general comments on it.
Yeah, I think it's an older machine, but it was, you know, hypoechoic nodule, mostly solid, maybe a couple small cystic areas, but I would call it predominantly solid. Again, I'm having a little trouble with assessing margins with this particular image, but it's, you know, more of an intermediate risk nodule.
So important from the perspective of timing, you'll know why it was done in July of 2020. We have some Doppler, some, I guess, blood flow.
Sure, and that's Doppler itself is not necessarily that predictive of thyroid malignancy, particularly in hypoechoic nodules. I think it can be in studies from Europe where they have higher prevalence of FTC. It can be more helpful where there's a higher prevalence, but with PTCs, it's higher places with higher prevalence of PTC, it doesn't seem to be as helpful, like from the US or Asia.
So patient cytology was positive for, was Bethesda 3, ATP of undetermined significance. It underwent a thermomolecular testing, which came back as benign. Risk of malignancy about 4%. 2 months later, patient noted enlargement of the nodule and ultrasound was repeated in September. So it's about, what, 3 months after the initial ultrasound. And nodule suddenly enlarged to 3.4 by 2.1 by 2.5 cm. FNA was repeated and cytology showed FLUS with cystic component. Thyroidic was performed. Before I show results, this is the new, probably a little bit better ultrasound machine, I believe. I don't know. anything here, any new findings here that would be different from the previous, Dr. Mayson?
It's clearly larger. It still looks hypoechoic. You know, one of my thoughts when you said it suddenly enlarged, could it have hemorrhaged into itself, which we sometimes see with partially cystic nodules after FNA, but it doesn't look like that to me. I don't think that's the case. I think this actually grew.
So cytology was AUS in this case, similar to the previous case. Thyroseq was performed, which was positive for PAX8 PPR gamma fusion. So this is one of the fusions that we discussed today. Maybe we will have a little bit more discussion tomorrow. That is a RAS-like mutation with slightly higher risk of cancers at RAS, and slightly about 5%, 5 to 10% of them are INJ invasive. So overall, it's kind of between low and intermediate risk. So I mean, I don't think that we have enough data to suggest lobe versus total. It depends obviously on nodule size and many other clinical parameters, but I'm talking about pure molecular sort of approach to this node. So at this time, what is your interpretation of the clinical, ultrasonographic, and molecular findings for this patient? Dr. Mayson.
I'm sure.
Sorry that I always asking you to do it, but you are our only endocrinologist star on this panel.
Yeah, so the one thing that concerns me in this nodules case is that kind of rapid enlargement over a relatively short period of time, which is very unusual with thyroid tumors, unless they, you know, like I described, hemorrhage into themselves and suddenly grow. And there it's usually overnight it increases and then decreases again. So in this, you know, normally I would have said a lobectomy in this person's case, but given that clinical history and correlating that with the molecular results, I would potentially consider a thyroidectomy, a total thyroidectomy. Again, I'd have a discussion about this with the patient and their surgeon, and kind of make a collaborative decision about it. You know, and that if they did do a lobectomy, there's a possibility they may need to go back and do a completion depending on the final pathology. But the one thing that makes me more concerned in this case is that rapid growth.
Dr. Gulec.
I would definitely agree with total choice. This is a fast, relatively speaking, fast-growing tumor, and it's a known fact that following FNA you may have bleeding, and this doesn't look like post-FNA bleeding. This is tumor growth. It is a sizable lesion. Even when you don't have this fast growth, it has 70% chance that this is a malignancy. Therefore, and it's a RAS-like tumor with potential to distant metastases, potential to respond radioactive iodine. For all those reasons, I would do total. If the patient is willing to accept very high possibility of a completion thyroidectomy and demands a total a lobectomy, then I might consider.
Very good.
Yuri, was this patient on second attempt was done with Afirma or only Thyroseq?
No, just Thyroseq was done second time.
Let me ask you this. In this particular case, if the Thyroseq was negative, what would you do then? There is a significant increase in size in a short period of time, and molecular testing by Afirma and Thyroseq negative.
If you're asking me, I would probably recommend a lobectomy, and if not, I would do close clinical follow-up of this person because I'm worried about that rapid change in size.
Well, typically when we follow, the endpoint is the change in size, which already is changed in size. So I probably would do a lobectomy myself because we hit the endpoint already.
It's a good point, yeah. So this is the surgery that was performed. On surgery, there was a follicular carcinoma, 3 cm in size with capsular and vascular invasion. So when I saw it, my only comment was that I think that they didn't specify how many vessels were studied. but other than that, that's the surgical outcome. So we have 2 minutes before 5 o'clock. So just your final comments. And one of the comments that I would like to hear from our clinicians is your feeling if in this situation you see there was a total thyroidectomy, there was a right surgery was performed, but if let's say this is a lobectomy was performed, would you consider completion of thyroidectomy in this case?
So what I was going to say is I didn't see there the number of foci of vascular invasion and the extent of capsular invasion on here.
That's exactly, Dr. Mayson, that's exactly was my comment, you know, when I saw it first time, that this report, you have to go back to a pathologist and request more detailed analysis of this.
I would probably mail it to you and ask our pathologist for an opinion about that, because I think that's really important. The other point I guess we forgot is also the patient had known thyroiditis, I believe, which also could have weighed into our decision making when we were making a decision about whether to do a lobectomy or a thyroidectomy. As you know, people with known Hashimoto's are much more likely to have postoperative hypothyroidism even after a lobectomy. So you're not saving the patient as much by doing them doing a lobectomy versus a thyroidectomy. But yeah, so I would ask for more information. But yes, I think likely this person may need a completion, but I'd need to know a little bit more about the extent of capsular and vascular invasion.
Dr. Gulec.
I agree. But a little surgical comment here. It's not a need for postoperative thyroid medication need. We also are very much concerned about the nerve. In fact, thyroid is about the nerve, but nothing else. Even in the best hands, it doesn't matter who does the operation. The risk is doubled when you do a bilateral operation. It's not the postoperative thyroid medication need, but also potential complications we consider.
Yeah, I agree. That's a really good point. I was thinking of what the patients often are concerned about, which is hypothyroidism.
Dr. Gulec,
you're absolutely right.
Dr. Gulec, what is the risk of recurrent laryngeal nerve injury with the upfront total thyroidectomy and completion thyroidectomy? Is it different or the same?
It's the same. It depends on how you do the first operation. If the contralateral lobe is not violated, the surgical space is not violated, this risk remains the same.
Very good. Okay, it's 5 o'clock. I want to thank our panelists. I want to thank all speakers, and I want to thank the audience for staying, for good questions. I hope that this was helpful for you, and thank you, and look forward to see everybody tomorrow at the plenary session of our symposium. Thank you and good night.